TRIBE looked at FOLFIRI-Bev versus FOLFOXIRI-Bev, saw an improvement in response rate, an improvement in progression-free survival, and what looks like an improvement in overall survival in the
So
final
why didn't
data.
we do this? It's a JCO paper.
Yeah.
It's an OS benefit. Why didn't we adopt this then? That's what, 2 years ago, that paper?
I think it was fear. To be honest with
Tox
you,
or
we weren't
uncomfortable with the
used to FOLFIRINOX. Now we're more used to FOLFIRINOX, so we're worried about the tox of the regimen. The other thing that I think is something people don't understand completely about FOLFOXIRI is that the way that the regimen was given in that study was for 4 to 6 months, and then they went on maintenance. So a lot of my folks that call me, they're like, why would I give FOLFOXIRI? It's using all the bullets in my gun at once. Don't forget I'm from Tennessee. It's all about bullets, right? So, but no, it's actually not, right? Because you're only giving it for a certain period of time and then you're backing off. So you can still use those agents
And so those
again.
agents are still on the table for a recycle.
Yeah.
Okay,
But to answer your question, I think one other thing that did temper the enthusiasm was in a sub-analysis, they looked at the ability of FOLFOXIRI to get you to a curative liver resection. And there was no difference, right? You weren't more likely if you got that kitchen sink approach to get it. And I know a number of oncologists said to me, I'm not doing it because it doesn't improve your likelihood of getting a curative metastatectomy.
I actually, that's the one place I do regularly use it, because it is a slightly higher response rate and stuff.
But the study didn't show it.
Yeah, I understand, but if response is what I got to get, to me that's a fairly reproducible response. But anyway, this study's different, though.
So the STEAM study is a little bit different. This was looking at a US-based population, right? So as opposed to the European-based population. This was looking at FOLFOXIRI versus what we call a sequential, where you got 2 cycles of FOLFOX, 2 cycles of FOLFIRI, 2 cycles back and forth, versus FOLFOX, all of them with bevacizumab in the arms, all of them with maintenance therapy after 4 months to 6 months, depending.
And the maintenance was?
Was 5-FU or capecitabine plus Bev. It was dealer's choice. And so the primary endpoint of this was looking at both response rate as well as progression-free survival. And what we saw is that you did get an improved response rate with the FOLFOXIRI versus the FOLFOX. We also saw an improved number of patients going to liver resection. So as opposed to the TRIBE data, we saw that about twice as many people went to potentially curative liver resection in the FOLFOXIRI arms.
And remind me, were patients stratified by we thought they might be resectable, or is just?
No, no, they weren't stratified.
Okay.
So it was just all comers across the board. Now, when we looked at the analysis, it looks like about the same number had liver-only disease versus extrahepatic disease. The other thing it looked at was the progression-free survival, and certainly when you gave FOLFOXIRI concurrently, you got what looks to be a better progression-free survival than if you used FOLFOX plus bevacizumab alone. So I think it's saying, again, maybe we should start thinking about using this triplet regimen, not only for our BRAF mutated patients, but is it something viable for more patients globally?
And the alternating schedule?
The alternating schedule didn't seem to be as good as the concurrent. So I don't think I would do the alternating schedule, but more the concurrent.
So they may be synergistic, OX and IRI? Is that what that's saying a little bit?
Well,
I mean, there's been some debate. Do we deconstruct FOLFOXIRI or FOLFIRINOX in pancreas, for example, or is there some
Well, they don't
magic
have to be synergistic if they're additive.
Additive,
right?
yeah.
If they work better together.
Well, I would have thought, oh, you mean, I was thinking they might be, you know, if you gave one and then the other, that you'd still see your additive benefit, but maybe not. Maybe they need to be on board center.
and I think the interesting component of this is the sequential approach, so giving FOLFOX and FOLFIRI, not in terms of necessarily a strategy to adopt, but more it's telling that you don't really need to throw the kitchen sink. You can get away with actually exposing patients sequentially with treatment. It may be more merciful actually on patients. The other thing, the PFS in the FOLFOXIRI doesn't look any different than the PFS with your other study with FOLFIRI alone. So I'm not sure. Versus FOLFOX.
Well, don't forget in the TRIBE study that was better.
Yeah, it was
right?
better.
So you don't want to cross-compare the study.
No, I understand, but it's still you're hitting the wall of 1 year, which is pretty much close to the 11 to 12 month you see with FOLFIRI, Avastin. The point of the matter is, I agree that there is a certain patient population that is likely to benefit from the triplet, yet to be determined. But I would not take a blank statement and say that FOLFOXIRI plus Bev should become standard for most patients.
So I've got a recipe here. I've got choices. And Richard, this is a little unfair. I recognize that because all of this is pretty fresh. But I've got a frontline, let's say, asymptomatic metastatic colon patient. My choices are everything from 5-FU Bev, or Cape Bev, which we see pretty good data with, right? So very simple, easy regimen, right? All the way to a much more intensive combination regimen. Tony's alluding to, could we figure out the right person in the absence of a biomarker? What do I do?
Well, I think it has to be really individualized on the patients. Obviously, you have to look at patient's age, patient's performance status, burden, tumor burden, right? Does the patient have a large 10-centimeter lesion, or does the patient have a few sub-centimeter lesions in the liver? So I think the decision of what to use up front will depend upon those multifactorial, including the biomarkers as well. So in terms of using, FOLFOXIRI, up front, the main concern is obviously some patients are a little bit older. The toxicity is a concern of those patients. But however, in subset of population, it definitely seems like those patients may benefit from FOLFOXIRI, especially with the patient with BRAF mutant or trying to downstage the patient for surgery. That's why I think, once again, we go back to the multi-D approach, that you have to present the case of tumor board to talk about, hey, could this be potentially become resectable later on? So I think that becomes a key point.
Well, our patients do want to be aggressive frontline, right? They want to push hard, and maybe it is slam the cancer, but being cognizant that you want to back off and do maintenance, because this is a maintenance study where you showed there was some difference from that initial approach. Charlie?
One thing that I think is really interesting about Johanna's presentation of STEAM is the fact that you do improve their ability to get a metastatectomy, to get a resection. That's what I wanted to see from these regimens, and the fact that you're demonstrating that, I'm going to think twice. When I see a patient who's resectable or more likely borderline resectable, I may very well do it.